rationale with the Arobase study was that endocrine therapy compared with chemotherapy has, in most patients, better tolerance. And then it has been claimed also that the addition of bevacizumab to endocrine therapy may be a better option than to combine it with chemotherapy. So this was a randomized study for patients with metastatic disease having an endocrine responsive disease, and they were randomized between endocrine therapy with exemestane, and those who were randomized to chemotherapy received paclitaxel. Both arms received the same type of bevacizumab therapy. The study was interrupted prematurely by the data monitoring committee because they saw in the first analysis after 117 randomized patients that there was no chance that the study would have a positive outcome. And the data for progression-free survival also demonstrate for those 117 patients that the PFS median value for the endocrine bevacizumab combination was 7.6 months, and for the chemo arm was at 8.1 months. So the study in total is, with low statistical power, flatly negative. Regarding the adjuvant experiences with bevacizumab, there are three major studies. The Beatrice study with almost 2,600 randomized patients, the Beth study with some 3,500 randomized patients, and the study now presented at ASCO by Kathy Miller with almost 5,000 randomized patients. If we take them one by one, the Beatrice study was focused on the triple negative subgroup. Standard chemotherapy was applied, and then patients were randomized to receive bevacizumab or not. The results was negative. The second study focused on the HER2 positive group, and that is, by the way, potentially interesting. While HER2 alteration are involved in alteration of angiogenetic control, so it would theoretically be an interesting subgroup to study. Despite that, the results are also negative in that study, as well as in the three-arm study now presented at ASCO, where there was no benefit to add bevacizumab to these 5,000 patients with primary breast cancer. Avataxher is a small prospective and randomized study including 152 patients, and it has a rather interesting concept, namely trying to identify patients who may have more or less benefit from bevacizumab. In general, that is the problem with almost all the bevacizumab studies, or I'm even inclined to say all studies so far, that it has not been possible, and the search may have not been that intensive as it should have been, to find markers outlining which patients do have benefit and which tumor characteristics define benefit or not. This French prospective study tried to look into whether you applied standard trastuzumab, docetaxel-based chemotherapy for the HER2 positive group in the neoadjuvant setting, and they applied PET investigation to look at the metabolism in the tumor. And those tumors having a more marked effect in downregulation of the metabolism, they continued the therapy as just described. Those patients who did not respond in the way one had the intention that they should respond, they were randomized to either continue this already started therapy or to add bevacizumab with the hope that one would increase the response rate and improve the outcome for the patient. The study is so small that it's impossible to draw any firm conclusion. It's not even, there are no solid statistical analysis of the material, but still it indicates that those who didn't have an initial response, if you added on bevacizumab, you seem to increase the response in those patients, indicating that PET camera investigation may be a method to investigate patients whom Bev maybe would have some value. But to say that it should have value, then of course you need to demonstrate not only that the tumors are shrinking better, that the patient really are surviving better, because that would be the ultimate goal by such strategy.